morning, everybody. I'm Dr. Alio from Alicante, Spain, and I want to welcome all of you to this session that we promise to be very interesting and instructive about 5 pills in cataract and ocular comorbidity. Ocular comorbidity is a frequent reason why our patients come for cataract surgery because they have other problems and they want to solve all of them at the same time. We have a distinguished group of speakers to talk about this and to provide to you practical information. I want to thank my co-chairperson, Dr. Natarajan, he's still not here, and we have a distinguished group of speakers, as I told you, dealing with cataract and glaucoma, age-related macular degeneration, uveitis, diabetes, and corneal disorders. We have the first speaker, Tin Ang, who is here, is the first speaker, and we'll talk to you about cataract and glaucoma. Thank you very much, Tin. Thank you.
Good morning, everyone. Thank you for attending today's symposium. And I'd like to thank the organizers for inviting me on this very broad topic of cataract and glaucoma. I have no relevant disclosures. I come from Singapore, and these are some pictures of Singapore, and from the Singapore National Eye Center, which is the main eye hospital in Singapore. So overview, today I'll give us brief concepts of handling cataract and glaucoma, but I'll divide it into open-angle glaucoma and angle closure glaucoma because the approach is a little bit different between the two. So for open-angle glaucoma and cataract, of course, you have several options, doing phaco alone, phaco with a MIGS, or phaco with trabeculectomy and mitomycin C. And you have to look at the disease factors, such as severity, the IOP control, number of medications, as well as patient factors, such as tolerance, the compliance, and the quality of life. And certainly for mild diseases, you would consider doing a phaco alone versus a phaco MIGS. And in this example of a patient with OHT, and certainly you would think of doing either a phaco alone or a phaco MIGS procedure. So MIGS is a recent, maybe over the last 10 years or so, where it's a group of surgeries where you have less destruction of the target tissue, maybe less in terms of aggressiveness of surgery and rapid post-op recovery. But the IOP reduction is modest. And there are various ways of looking at MIGS, whether it's through the meshwork or Schlemm's canal, through the suprachoroidal space or subconjunctival space, and each have different pros and cons, and some of them involves the use of devices, and others do not need devices. But there are 3 big pivotal MIGS studies where they compared phaco MIGS versus phaco alone, and one was using the Hydrus, the second one was using the CyPass, and the third one was using an iStent inject. And all 3 studies were FDA trials where they recruited all in excess of almost 400 patients with phaco MIGS compared to about half the size for phaco alone. And you can see here the mean deviation was about -3 in all groups, as well as the number of medications were about 1.7 pre-surgery. And the washed-out IOP was in the range of 24 to 25 millimeters of mercury. But what's very interesting in all these trials was how phaco alone was consistently shown to reduce IOP by 5 millimeters of mercury, showing you the effectiveness of phaco alone in POAG and OHT. You can see here that all 3 trials showed similar effect of phaco alone. However, of course, if you looked at the effect of the MIGS, it was slightly higher, about 2 millimeters higher for the Hydrus and about 1.7 for the CyPass and 1.6 for the iStent inject. And so certainly there's an option for mild cases of POAG and cataract. For more advanced cases of open-angle glaucoma, of course, you need to think about whether phaco MIGS is sufficient or whether you need to combine it with a trabeculectomy with mitomycin C. And this is the gold standard in terms of glaucoma surgery, in terms of IOP lowering in the long term. And the problem, however, there's some complications of doing augmented trabeculectomy with mitomycin C, including risk of hypotony, bleb-related infections in the long term, as well as failure. So these are potential issues. We move on now to angle closure glaucoma, and this is an important form of glaucoma, especially in this part of the world. And in angle closure glaucoma, the predominant mechanism in many cases is pupil block, and that's why you do an iridotomy in the early stages of the disease. But we also know that when you do an iridotomy, some angles do not open up, and this is because the iridotomy only treats the pupil block element, and there are other mechanisms involved in angle closure, including the lens, the ciliary plateau iris, and others. And the lens is really a major factor in angle closure glaucoma. You can see here the effect of removing the lens in angle closure. It opens up the angle well, and it lowers the intraocular pressure. And this is a patient with a very large lens vault. In this kind of cases, there's no point doing an iridotomy. You should straight away take out the lens. And remove the lens will also remove the pupil block element. So currently, for management of angle closure glaucoma, we also look, the first question we ask is there a significant cataract? And if yes, should we consider a phaco alone? And this should be considered for milder cases of angle closure with not so severe visual field loss or optic nerve damage, and perhaps with less medications. But if you have more severe cases of angle closure glaucoma, we need to consider, should we combine it with a phaco, with a trabeculectomy and mitomycin C? And there have been several trials looking at this topic of between phaco and phacotrabeculectomy. I'd like to quote studies from the Hong Kong group by Clement Tan. He did 2 trials, one for medically controlled angle closure glaucoma, which were the more milder cases, and one for the medically uncontrolled angle closure glaucoma. And both trials showed that phaco alone did very well in terms of IOP lowering, but there was, of course, a slightly higher IOP lowering efficacy with phacotrabeculectomy. You can see here the results both in the medically controlled group as well as the uncontrolled groups. So phaco alone is a very good option as well for angle closure glaucoma, but for more advanced cases, you may need to add it with trabeculectomy, mitomycin C, for the higher IOP lowering as well as the fewer medications and post-op on follow-up. What about acute angle closure? As you know, it's an emergency. It's a very common medical emergency in many of our accident emergency departments. And even for acute angle closure, there have been trials looking at phaco alone versus a laser iridotomy. And I'd like to quote the one trial from Singapore and one from Hong Kong. And in both trials, they did a very early phaco within the 2 to 3 days of presentation of acute angle closure. And you can see the Hong Kong study here. At 1 year, you can see the results were much better in the phaco alone group, at least in terms of IOP lowering. There's much less people who needed medication. Only 3% needed medication in 1 year, compared to 46% in the laser iridotomy group. And the Singapore group also showed similar results at 18 months here. You can see 2 years here, the Singapore group also showed almost 99% success for the phaco group compared to 60% in the LPI group. So definitely, we would definitely do an early phacoemulsification for acute angle closure as well. But when do you do it? I think in the trials, we did it in the first 2 to 3 days, but nowadays we probably wait for a while to let the eye settle down, reduce inflammation, and do an early phacoemulsification maybe within a month of the attack. Let me just delve into 2 quick issues about angle closure, glaucoma, cataract extraction as well. One is goniosyncytiasis. In the cases of acute angle closure with lots of synechiae, should you do a phaco-goniosyncytiasis? And we did a trial in Singapore comparing phaco with phaco-goniosyncytiasis, and we were surprised to find that the effectiveness of goniosyncytiasis was not superior to phaco alone. You can see the complete success rate was similar, and IOP change was also similar in terms of phaco GSL with phaco alone. And showing you that although anatomically it may open up the angle, the efficacy-wise, the IOP reductions was similar. And Tanuj Dada in Delhi also did a trial comparing phaco with phaco GSL, also found similar success rates of phaco alone with phaco GSL. So perhaps, even if you break the PAS in case of angle closure glaucoma, the threshold may not be functioning, and so it may not be effective enough in terms of IOP lowering. What about phaco mix for angle closure? He has very limited data so far. There have been many case reports and case series for phaco mix, and certainly for the devices that you place in the Schlemm's canal, there's risk of occlusion. But recently, there's been a trial going on in China, led by Zhang Xulan, where she compared phaco-goniotomy and goniosyncytiasis with phaco-trabeculectomy. And they found really effective, good results for phaco-GSL goniotomy. And certainly, this is something we should watch out for future data. The last issue is that of clear lens extraction, and there's an EAGLE trial, which is a multi-center trial, which looked at cases of clear lens extraction for angle closure glaucoma. And they found at 3 years that the clear lens extraction group did slightly better in terms of quality of life as well as IOP lowering compared to laser iridotomy. And certainly we are moving towards earlier lens extraction in angle closure glaucoma, but perhaps not so much clear lenses. I think clear lenses is perhaps slightly more aggressive approach, and you should discuss this approach with your patients. But remember, these are angle closure can be difficult cases, and there are risk of complications. And certainly, if you do a clear lens extraction and you develop cataract complications, this will be very bad for your patient. And certainly, you need surgeons who are experienced and able to handle such cases. So in summary today, I've given you an overview of the management of cataract and glaucoma. So for open-angle glaucoma and cataract, I think you have options of phaco alone, phaco mix, or phaco trabeculectomy. And the amazing results of the mixed trials showed the effectiveness of phaco alone of at least 5 millimeters of mercury lowering in open-angle glaucoma. But phaco mix had additional efficacy about 1 to 2 millimeters. And certainly you reserve phaco trabeculectomy for the more advanced cases. For angle closure, we know the importance of lens in angle closure, and certainly we consider phaco alone as a primary treatment for many patients with angle closure glaucoma. Of course, those with the more severe cases, you may combine that with a trabeculectomy and mitomycin C. Consider doing earlier lens extraction for acute angle closure, as well as in other cases which are other cases of angle closure. But remember, phaco in extraction in angle closure eyes can be technically challenging with high risk of complications. Finally, I'd like to talk to you about fellowship programs at the SNEC. We do accept international fellows from all different subspecialties. We do have paid fellowships, usually at least for 1 year. And also like to invite you to Singapore next year for the Asia Pacific Glaucoma Congress, as well as the SNEC 35th anniversary in the 24th to 26th July next year. Thank you for your attention.
Thank you very much. A very interesting and instructive presentation, Tim. I would like to make you a couple of questions, because we have some time for discussion. This is a session for practical indications. So the first one is, as cataract glaucoma is the most frequent comorbidity that happens to be in cataract surgery, when do you consider that should be mandatory, indicated, combined surgery, and when is not? In other words, when you have no doubt either to do with a glaucoma surgery or to do yourself, being a cataract surgeon, the surgery. So in main indications. And the second question is, which is the main technique that should be in the hands of a cataract surgeon? Some of these techniques are for glaucoma specialists, while others are not. So which ones do you recommend as more appropriate for cataract surgeons? Thank you, Tim.
As I said earlier in my studies, phaco alone is a very effective IP lowering effect in all forms of glaucoma, open-angle glaucoma as well as angle closure glaucoma. And certainly you could consider phaco alone as a first-line option in many patients with coexisting cataract and glaucoma. And you can see the IP lowering is very decent for open-angle glaucoma, about 5 millimeters of mercury, and for angle closure, even higher in many cases. And certainly, but the more advanced cases, then perhaps the cataract surgeon should consider referring the patient to glaucoma surgeons to consider either combining it with a trabeculectomy, or even a phaco mix for the milder cases could be considered, if they are proficient in mix.
Thank you very much. Any question? Nothing? Any question from the audience? No questions? Well, thank you for this very self-explanatory talk. Thank you. And let's move to the next comorbidity topic, which is going to be developed by Dr. Shobha Sibri-Prasad. He's going to talk about cataract and age-related macular degeneration, AMD. Thank you. Together with glaucoma, AMD is the most frequent comorbidity that we have today in cataract surgery. So thank you for this presentation. Thank you.
Thank you. And also thank you to the organizers for inviting me to talk on this topic today. So it's a pretty short topic, cataract and age-related macular degeneration. These are my disclosures. So the two main objectives or two main questions we are often faced with is, does cataract surgery increase the risk of AMD progression? And number two, how do we manage cataract surgery in the presence of patients with neovascular AMD having anti-VEGF therapy? So I'll focus on these two. So there are several population-based studies done in 1990s that show that history of cataract surgery increases the rate of progression to late AMD. The odds ratio is as high as 3 to 5 times increased risk. So when you consider these patients in the epidemiological studies, you will find that cataract with early AMD at baseline were more prevalent in these earlier population-based studies than what we have today. So therefore, it is invariable that their natural progression is they are more likely to progress. It's not due to the cataract surgery. Now we have more recent clinical trials, that's the AREDS and AREDS2 preparations. And in both these clinical trials, it was shown that there is no increased risk of late AMD progression with the cataract surgery, both at 5 years and a median of 10 years follow-up. So that clearly shows in AREDS that there was no increased risk. Again, when we did AREDS2 sub-analysis, it again showed that there was no increased risk. So both these clinical trials contained patients with AMD, but they did not show progression to either neovascular glaucoma or geographic atrophy or both. So why are these results contradictory? So earlier studies suggest that there is increased risk, while clinical trials suggest that there isn't. So the AREDS and AREDS2 trials, as you know, were done in a much healthier population. They did have AMD at baseline, but maybe not as severe as what we knew of when the population-based studies were done. For example, the Beaver Dam study, the Blue Mountain Eye study, etc. So in those studies, 2/5 of the cohort had high-risk characteristics of late AMD even before the cataract surgery was done. So they are more likely to progress, and it is not as a result of cataract surgery. So this is the first objective, and we showed that you can do your cataract surgery without any fear of progression. And if it progresses, it's just bad luck. It is the disease natural history that has taken over. The next question is, what is the visual outcomes after cataract surgery in eyes with neovascular glaucoma? Neovascular AMD. And you will see that in many of the studies like Marina, the Anchor studies, where cataract surgery was done in patients with neovascular AMD having anti-VEGF treatment, there was a 2-line gain in vision on average. So visual outcome is good in patients with neovascular AMD having anti-VEGF therapy being operated for cataract surgery. For the patients who were in the AREDS trials, both AREDS and AREDS2, when they had their cataract surgery, a high proportion of patients had 20/40 or better. Again, these are clues suggesting that there is no use delaying cataract surgery in these patients. What about in patients with eyes with geographic atrophy? Here again, of course, if they are center involving geographic atrophy, they are unlikely to improve visual acuity as a result of cataract surgery. So the question is, do we do cataract surgery in such patients? Yes, we should, because it improves other aspects of visual function, such as contrast sensitivity, color vision, field of vision, glare, and also quality of life. We have to make these patients as independent as possible, and therefore we should not delay cataract surgery for them, or even avoid this surgery. So the next question is, how do you manage cataract surgery while a patient is on anti-VEGF therapy for wet AMD? Here, as I said earlier, cataract surgery should not preclude intravitreal injections, so you can either give the anti-VEGF injections before the cataract surgery or during the cataract surgery. Now, if a patient is having active neovascularization with activity, you can see in terms of fluid accumulation, try to treat them with anti-VEGF and dry them as much as possible. But we know that a significant proportion of patients may have persistent fluid and is in need of cataract surgery. In that instance, we would do the cataract surgery and give them anti-VEGF either pre-operatively or during the procedure. The next question is, what is the type of lens that you would use? To date, the benefit of blue intraocular lenses are not universally accepted. So in conclusion, there is no increased risk of progression to late AMD due to cataract surgery, so we should not delay cataract surgery just because a patient has AMD, either early or non-foveal involving geographic atrophy, or even wet AMD. Please do them. in eyes with neovascular AMD, where we can dry the macula as much as possible, please do so prior to cataract surgery. If you can't, then you have to give the anti-VEGF before or during cataract surgery. The type of IOL that we put in the lens, the evidence is equivocal. The benefits of blue IOL is doubtful, and evidence is also limited in terms of new generation implantable miniature telescope and the like. Thank you very much.
Thank you very much, Dr. Sibli Prasad. We have the presentation open to questions. And again, we are in a comorbidity session with practical tips, you know. And I think that your topic has 3 stages. First is pre-op. I think that every patient for cataract surgery, everyone, should have a pre-op macular OCT, especially if you have a patient over 65, because AMD is very frequent. I think that is more frequent in Europe than here. Still, studies on prevalence are not clear in terms of ethnicity, but we have a lot of cases, probably because of the aging of the European population. So, first of all, do you agree with this statement? Because it's an added exam, an added cost to cataract surgery, to have a macular OCT in every patient pre-op.
That would be good if we could do that, but in a specialty like, for example, I come from Moorfields Eye Hospital. Our cataract team is different to medical retina team, and therefore, if patients are sent in for cataract, they do an ordinary fundus examination, and there's no evidence of AMD. They do not usually go ahead and do OCT in those eyes. But of course, if there is any doubt that there is a posterior segment pathology, then definitely OCT first before you embark. So it depends on the capacity of the clinics, depends on the protocols followed by each trust. I would have loved OCT for every patient because we do see surprises at the back of the eye, especially after cataract surgery. You suddenly realize this patient actually had irreversible damage at the macula due to any cause. So yes, that would be good practice, but may not be applicable to all nations.
Good. Second question is, you rightly pointed out that we have a problem today with the intravitreal injections and cataract, because these patients are receiving dozens sometimes of injections before they go for cataract surgery, and we do know that there is a risk involved in the cataract surgery when these injections have been provided. Which preventive measures do you indicate for those cases in which preoperative intravitreal injections have been performed for the cataract surgeon to be taking some preventive measures for complications?
Yeah, I mean, repeated intravitreal injection is associated with zonular weakness, right? So we need to consent the patients in such instances that, you know, it may end up with a complicated cataract surgery. We have to take all precautions to avoid such zonular dehiscence during the operation. But that is after repeated intravitreal injections. So if a patient has had, I don't know the threshold at which you will start consenting the patients about complications during cataract surgery, but I would say there is an association with that. Secondly, before the cataract surgery, definitely do OCT and treat the patients with anti-VEGF as much as possible. I would say until stabilization is reached before we embark on cataract surgery. But, you know, I think people who are doing medical retina clinics here and giving patients injections very regularly do know that there are some patients where, despite all anti-VEGF therapies, we may not be able to dry the macula. In those instances, I will still go ahead, explain to the patient, either give one dose preoperatively or during the surgery.
Thank you. Now the third question, okay, that will be 5. The third is what IOL to choose, because we have a patient that has early changes, drusen, you know, but still have a good visual potential. You perform visual acuity test, a potential visual acuity, and the vision is good. So why not to use a multifocal or a modern EDOF or a monofocal? So what is your position, which is your advice to the audience about IOL choice?
I am quite skeptical about doing multifocal lenses in patients with AMD. It's just because we don't have enough evidence on that. And I wonder how they will fix with this multifocal lenses. You know, people often struggle, but there is no strong evidence. And it might be that we get a paper tomorrow saying multifocal is just as good. in that case, of course, we will start to opt for multifocal. The jury is out there. It's really difficult. I would still go for monofocal and give them reading glasses or the like, or give it the other way, allow them to have some reading vision and correct for distance.
Okay, thank you, clear. And now, finally, we have these telescopic or magnifying intraocular lenses. They are very necessary because obviously we have many patients that cannot read properly, and just with normal glasses, they don't read well. These ultra magnifiers, let's say, are conflicting because the experience, as you rightly mentioned, is limited. So which is your position, which is your advice, or which one do you recommend, if any? Thank you.
At present in the UK, we do not recommend it, miniature telescopic lenses, but it is becoming lighter and easier to implement. And also, these patients do not have anything else. Their low visual aids do not work for them. They are desperate. In such cases, with patient consent, we can still do it. I think we have to accumulate real-world evidence on how it performs and probably use that. A clinical trial on that is extremely difficult, A, to get the patients, and B, to follow up these patients because there's a lot of subjective element in that.
Yeah, true. It's very limited, unfortunately. And there are two types. One, those that are really magnifying a lot based on Galileo principles, they amputate the peripheral visual field.
Yes.
And this is one important problem for just orientation. But the second are those that are not related to visual field amputation. They are based on a peripheral field magnification, and still the evidence is very controversial.
Yes.
So I don't have a clear idea, and I think that clinical studies need to be performed. So,
Thank you.
Any other questions from the audience? No? So thank you very much. Please sit down here, and Tim, you are invited to join the panel, okay? Fine.
My bag is just down there.
No, please. No, sit down here. Yeah. Thank you very much. And now we have the third comorbidity, which is dealing with uveitis. And uveitis is a rare disease, but they are frequent in hospitals, especially academic centers. And these patients really have cataract always. They have cataract related to the disease and the treatment, and they feel the need of cataract surgery when they are still young. So it's very important to make a right indication. So Prima Kloski and experienced doctor and specialist in uveitis will deal about this important topic. Thank you.
Great. Thanks very much. Thanks very much to the organising committee for asking me to be part of this. So I thought what I would do is, because we're talking about 5 pearls, is give you 5 pearls for managing patients with uveitis and cataract. Cataract is one of the commonest complications that we see in uveitis. It's certainly extremely common in patients with chronic anterior uveitis and with Fuchs cyclitis or Fuchs uveitis syndrome. It's a little less frequent in posterior segment and pan-uveitis, but it's common in all forms. And of course, we have the confounding factor of steroid therapy, particularly topical and regional and intravitreal steroid therapy. So my 5 pearls really are a sort of a framework to help you manage these patients through cataract surgery. So you've got to know what sort of uveitis you're dealing with. Make sure you've got a stable sort of management strategy instituted and that the uveitis is quiet. Develop a good surgical plan. Think about which patients need increased treatment during and post-operatively, and then follow these patients closely. So the clinical phenotype is really important because Fuchs uveitis syndrome or Fuchs cyclitis, yes, you get some minor hyphemas during surgery, and post-operatively the patients complain because we focus their floaters really very acutely, and so these patients are always unhappy for a period of time after surgery because we've made their floaters much worse. In distinction, someone with chronic anterior uveitis is a much more complicated surgical patient to look after. They often have synechia, bound down pupils, they may have high or low pressure, they often have cystoid macular edema, so they're a very challenging group of patients sometimes to look after. And the important thing about posterior segment involvement, be it posterior uveitis, intermediate uveitis or pan-uveitis, is these patients need increased treatment perioperatively to minimise the risk of post-operative complications. And the other group, of course, are patients where there's a history of cystoid macular edema. These patients need increased treatment as well. The best way to minimise all of those things that I've spoken about is to make sure that the uveitis is stable and regressed and quiet for a minimum of 3 months before you embark on cataract surgery. It's really important to control the intraocular pressure. It's also important to think preoperatively, is this one of those patients we talked about that's going to need increased steroid cover perioperatively? And if at all possible, you have to avoid operating on an actively inflamed eye. Sometimes it's not possible. Some of those patients with chronic anterior uveitis, it's just not possible to get them completely quiet, but that should always be our aim. And as I say, a minimum of 3 months before you do that. And you want to make sure that their treatment regimen is stable before you embark on surgery. It's also important, of course, to have thought very carefully through the sort of perioperative management. So preoperatively, you want as accurate biometry as you can. If you can't get a good view of the posterior pole, a B scan is important. You need to use an experienced surgeon when you're doing these cases. They can be really complicated intraoperatively, and so the more experience that you have when you undertake these cases, the better. So the sort of things you need to think about in developing your surgical plan: where should you put the incisions? Sometimes peripheral synechii and corneal opacities mean that you have to move your incisions away from where you would normally do them. You've got to think about, is it likely to be a rock-hard cataract? Is there damage to the sort of lens capsule? Are the zonules intact? Is the AC shallow? What sort of work are you going to need to do on the pupil to gain access to the cataract? And sometimes the posterior synechii are extremely broad, and there's sort of broad adhesion of the iris pigment epithelium to the anterior lens capsule, and these can be very difficult sometimes to break down. And additionally, they're often pupillary membranes, which occasionally even can be a little vascularized. The other important thing preoperatively is to counsel the patient that they're going to have an increased risk when they have their surgery. There's increased risk of lens dislocation and posterior capsule rupture, and they're going to need close follow-up post-operatively. And the patient needs to be aware of all of these things before you embark on cataract surgery. You also need, as I said earlier, to think about how you're going to manage the iris and the pupil. You often need to do synechialysis, viscodissection, some sort of pupil stretch. You often need to use iris hooks or a Malugan ring or some other device to give you a large enough pupil to be able to use the cataract. You often need vision blue and other sort of techniques to make sure that you can visualize the capsule to give you the best chance of getting an intact rhexis. I'm a great believer in less is more, so I still use iris hooks. They've been around for a long time. They're relatively easy to use. There are a few sort of beginner tricks that you need to be aware of, such as how you angle the side port knife to get the iris hooks down to be parallel to the plane of the iris. But iris hooks are easy to use, easy to remove, and they work extremely well. Once you have completed your phaco, then you've got to put in an intraocular lens. These are not contraindicated in patients with uveitis. In children, in older children, it's safe and important to put in an intraocular lens if you can. Often the pupil has been badly damaged by the uveitis, and sometimes you need to reposition the iris to get the pupil into a sort of the most appropriate site so that minimises the risk of it sticking to the edges of the capsular rhexis, and that you have a pupil that's small enough to minimise glare and photophobia post-operatively. Sometimes I'll put in an iris suture or do a pupilloplasty to get the pupil down to the right side. That's not uncommon in patients with herpetic-related keratouveitis, where there is a lot of damage to the pupil. The other important thing is to think about whether you might need capsular tension rings, Cioni hooks for the capsule there and the bag. It's really important to think through and be happy to use any of those surgical techniques if you need to. And as I mentioned, it's with your positioning of the iris and the pupil, you try to minimise the risk of adhesions between the iris and the capsule. The next important thing is to determine whether the patient is going to need increased cover for their surgery with steroids. And so certainly if it's an only eye, or you had a poor outcome in the first eye, a documented history of significant cystoid macular edema, patients with chronic anterior uveitis where you're going to need to do a lot of iris manipulation, and the majority of patients who've had significant pan or posterior uveitis. We don't need usually to use systemic steroids in patients with quiescent recurrent acute anterior uveitis. Topical therapy is usually enough for them, and you don't need perioperative oral steroids for patients with Fuchs uveitis syndrome. In terms of what to do with your perioperative steroids, there's absolutely no universally accepted regimen. The principles are that you need to increase topical therapy preoperatively. Most of us will increase topical steroids 3 to 5 days before surgery, pre-treat the patient with topical non-steroidals. I use the same regimen that I learnt when I was a fellow many years ago, and I just use 40 milligrams of prednisolone for 14 days preoperatively. Other people use 60 milligrams for 5 days. Other people use that for 3 days. As I say, there's really no universally accepted regimen. Intravitreal steroids are also very useful, particularly in patients where oral steroids or other forms of systemic steroids are potentially a problem. An Ozurdex is a really useful thing to do a week or so preoperatively if you can, or certainly on the table at the end of the procedure. And if someone is on regular intravitreal therapy, you time the surgery in between their injections. Post-operatively, it's important to remember that there is an increased risk of significant severe post-operative inflammation, a flare-up of their CME, and a relapse of their uveitis. And any or all of those things can happen in the same patient. So we need to make sure the patient understands that before we embark on cataract surgery. As I say, we pre-treat them with intensive topical therapy and use systemic steroids as top-up therapy as needed, and slowly taper that back to their regular preoperative dose. Fibrin deposition from all that iris and pupil manipulation is quite common, and you often need to really use intensive treatment to control that. If it's available, I find TPA just intracamerally just dissolves the fibrin sort of magically over about 30 minutes after you do that, and that's a really useful strategy if that's available. If someone's cystoid macular edema and or uveitis relapses after treatment, the first thing that we'll do is consider local steroid therapy, usually regional steroid therapy, either orbital floor or intravitreal therapy. And Ozurdex, as I say, is really very useful if you're able to access those, or Triessence or orbital floor triamcinolone is really useful. Again, systemic therapy is often also needed, and I think there's excellent evidence that high-dose oral steroids and combination immunomodulatory therapy is really very successful at controlling uveitis, but you often need increased steroids post-operatively to control any relapse of uveitis. So to finish off, these are the 5 pearls that give you a good framework, I think, to manage patients with uveitis who need cataract surgery. So know what you're dealing with, make sure it's quiet, have a really well-developed, thought-out surgical plan, not only for the surgery, but also for the medical management of these patients. Make sure that you pre-treat and increase the oral therapy in patients who need it, and follow these patients closely. Thank you very much for your attention.
Thank you, Peter. Thank you very much. And we have, again, a couple of questions. One is, the first is when not to use an intraocular lens. That has been a big debate always, but today there is not a clear lack of indication, right? Because the problem, especially in young people, is that efficacy is very, very negative in these low vision patients for postoperative medical education. So
well, I guess
what would you do?
The major group are the children, particularly those with JIA. And previously, if you were a younger child, and by that I mean under sort of, I suppose, 7 or 8, we were really hesitant to use intraocular lenses. But I think the advent of adalimumab and biologic therapy, the Sycamore study that showed really very convincingly that biologic therapy for patients, for children with JIA, really suppressed the disease and gave you that stable platform of sustained control of the uveitis, has been a major change in our management. In my unit, we now do far less cataract surgery on those children than we used to, because now we can finally suppress the disease. And our aim is to really let the child become as old as possible before doing cataract surgery. And children have such good accommodation that often they can have relatively poor distance vision, but they can still read, do their schoolwork, use screen-based equipment. So we'll try and delay surgery until they're older, so that then their eyes are closer to adult size and it's safer to put in an intraocular lens. So it's uncommon now that we won't use an intraocular lens.
Thank you. And the most frequent post-op problem, for me at least, is macular edema. Macular edema is a hell. Many times you have it pre-op, many times you increase post-op, and sometimes it appears in the post-op, and they don't respond many times properly to the treatment. So how do you manage this late and reluctant to be effective in treatment cases with post-op macular edema?
Yeah, no, I think I agree. It is a really very difficult problem in some patients, and sometimes surgery really sort of alters the profile of their macular edema, makes it much more treatment resistant. So I guess the sort of things that go through my mind are we try and maximise each of the therapies, be they regional steroids, making sure that, say in a vitrectomized eye, an Ozurdex and intravitreal triamcinolone, the effectiveness of that is much shorter, so you may need to give the injections more frequently. Make sure that the patient's actually taking the medication the way you want. We have a very low threshold for escalating their treatment, and certainly introducing a biologic, which is often very useful in these really recalcitrant cases. And the other thing is to think about traction. Now that we've got OCTs, we certainly see a lot more epiretinal membranes than we thought existed. And although it's difficult sometimes to sort out how significant the tractional component is, I not uncommonly will get the VR surgeons to have a look, and we'll have a think about whether relieving any macular traction may be a useful strategy.
Thank you very much. Any question from the audience? Doctor, yes?
I want to know whether you are using intracameral triamcinolone in some cases of anterior uveitis post-operatively, at the end of the surgery.
Yeah, I certainly use it to visualise the vitreous if we're unlucky enough to have come across that from the anterior approach. But I don't routinely use it intracamerally post-operatively for an inflammatory response. I would rather give subconjunctival steroids, but I see no reason why you shouldn't.
You don't use it?
No.
As a form of steroid therapy?
Yeah, no, I mean, if you think back, Ozurdexes were originally developed to manage anterior segment inflammation. So they have been used, and I know people who use it. I personally have no experience.
Okay, thank you very much, Peter. Great lecture. And now we have the next speaker dealing about important topic, which is cataract and diabetes. Julia Chang will be in charge of this important topic, and thank you for coming to this session. Thank you very much.
Thank you very much for the kind introduction. It has been a pleasure to be here, listening to the 5 pearls of other cataracts and comorbidities. So unlike the other presentations, diabetes is a systemic condition. And this condition will affect how we should approach these patients and how to offer the best treatment to them. So I have no conflict of interest in the coming slides. So before I begin, I'm really thankful to be here. Yesterday I went to Agra, where there is the baby Taj, where there is the jewel box. It's very nice to be there. And today we are trying to also open the jewel box of finding the pearls of doing cataract surgeries. So why is diabetes mellitus important? Because it's a pandemic. It happens to our daily clinical practice, and we see diabetic patients either undiagnosed or poorly controlled all the time. In India, the prevalence is quoted to be 8.9%, and in Hong Kong, it's 5.4%. Nevertheless, with the aging population, it's estimated that the prevalence of diabetes will strike up to even 33% by 2050. So there are a number of reasons why cataract occurs more in diabetic patients. It's quoted that there is a 2-fold increase in those patients with diabetes having a cataract progression, especially in age after 65. Of course, there are multiple reasons for the progression, some being osmotic stress. Others could be an accumulation of sorbitol inside the eye. So what cataracts do we manifest in patients with diabetes? It's quoted that the odds ratio is 2.2% in cortical cataracts, 4.5 odds ratio in posterior subcapsular cataracts. Unlike popular belief, is the association with nuclear cataracts is actually quite weak. And in type 1 diabetes, where patients manifest really early age on, we do see some snowflake cataracts. So what are the considerations we have to take? Of course, it's the timing of surgeries. Back in the 1990s, it is a common belief that we should delay the surgery until the visual acuity drops into 2100. It is because they think that the principal thinking is that DME is the majority cause of poor vision, and the major cause for poor vision is not cataract. And there's a risk of having a diabetic retinopathy progression with early surgery. However, the mindset has been switched since 20 years ago. Having an early surgery benefits the patient because it allows ophthalmologists to have a better monitoring of diabetic retinopathy. It allows better penetration of PRPs and also leads to better patient outcome. So after the timing is considered, let's talk about the preoperative assessments in these patients. Of course, it's very important as a systemic disease, we have to also ask history regarding the diabetes control. The duration, of course, make a major role on how it affects the patient, the current medication, and also we have to screen for systemic diabetic complications because these microvascular and macrovascular complications do have an impact on us estimating how severe the diabetic retinopathy or potential difficulties in having these operations. Of course, the common examination has to be performed, but the particularly thing we have to look at is, of course, those related to neovascularization. We have to actively perform gonioscopy, cystoid macular edema, as we have said, maybe perhaps performing an OCT beforehand could be beneficial to these kinds of patients. And because the diabetes will affect the parasympathetic pathway, the pupil diameter is often small, and these will lead to a very difficult cataract. And of course, screen for diabetic retinopathy. So the pearl is that we have to treat the existing complications first to optimize the patient's ocular condition before we carry forward, perform pan-retinal coagulation if necessary, and inject anti-VEGF if needed. And if we detect any tractional retinal detachment, liaise with our VR colleagues to see how this can be managed. Perhaps a combined surgery should be performed in these kinds of patients instead of separating surgeries. So in terms of surgical techniques, in principle, the diabetic retinopathy progression related to cataract surgery is proportionate to the time of the surgeries performed. So if possible, seek senior surgeons, experienced surgeons to doing it, and try to limit the time struggling on the patient's eye by completing a more comprehensive workout beforehand. And also perform a larger capsuloresis and come back with poor mydriasis in these kinds of patients. For capsuloresis, we aim to do a slightly larger capsuloresis, and which covers the optic edge. So this is an operation showing that with a slightly larger capsuloresis, with covering all the optic edge, it will prevent patients from having anterior capsular phimosis, which will benefit the patient. And in patients, as I have mentioned, because these kinds of patients has impaired parasympathetic control and also prostaglandin affecting, so these patients tend to have very small cataracts. So as our last speaker has mentioned, we have to do things to help with the enlarging the pupil. Of course, preoperatively give adequate mydriatics, but in this kinds of patient, it doesn't work. It's not responsive. So we try to use viscoelastic to try to enlarge the pupil first. If it fails, then we have to do things to optimize our view. First, by doing some capsular staining, and also use Kruger hooks, if possible, to try enlarging the pupils. But often it doesn't work in diabetic patients, to be honest. So in this particular patients, both of the things we have done doesn't work. So I also agree that iris hooks is very malleable, adapts to different conditions, even in patients with very shallow anterior chamber, unlike capsular ring, which requires a patient to have a very deep anterior chamber. So in this particular patient, I also put capsular hooks and perform the phacoemulsification in this patient. So how about the consideration for intraocular lens? It is commonly believed that square-edged IOL will help prevent PCO formation, and this will help us better visualize these patients in postoperative monitoring. And of course, some studies that hydrophilic lens will cause more progression and more opacification. And in the back implantation is the most anatomical implantation of the lens. It prevents postoperative inflammation and is good for the patient. So, to wrap up my presentation, after an uneventful cataract operation, we have to do a very fast surgery. We anticipate there will be small pupil, and we have done our appropriate capsuloresis. So what do we have to do later? Of course, we have to anticipate for potential complications. In patients, particular with diabetes, we have to watch out for any cystoid macular edema or Irvine gas syndrome. We have to monitor for progression of retinopathy, and also to combat with posterior capsular opacification in these kinds of patients. So the treatment is to treat early, be aware, and to actively think what should be done in patients who doesn't have a apparent vision improvement post-cataract surgery. We have to liberate use of topical steroid NSAIDs and follow the protocols of treating DME if possible. In DR progression, with better view after cataract surgery, frequent monitoring and administrate appropriate treatment is essential. And of course, early YAG capsulotomy, perhaps 6 months after cataract surgery, can be performed in these kinds of patients. to ensure even better view. So to conclude, as we said, diabetes is a systemic condition affecting a large population, so this should be actively monitored and actively taken care of. We have to optimize our patients and be prepared for potential intraoperative complications with better planning, liaise with experienced surgeon, and to give early treatments to postoperative complications. And last but not least, not only APAO, but also ACS will be held in Hong Kong next year, 2026. We look forward to welcoming you all to Hong Kong. Thank you so much.
Okay, thank you very much. This was a great talk, Dr. Chan. And I have two questions. The first one is about how to evaluate the visual potential of the patient, because frequently you have, especially middle-aged people, persons that come from years ago with macular problems. They have had injections, they have had pan-retinal photocoagulation. Sometimes it is difficult to evaluate the visual potential that these patients have, and if this visual potential justifies a cataract surgery. So there are some methods to evaluate appropriately, like the potential acuity meter, retinal acuity meter. Which one do you use to estimate the visual potential, and in this way to indicate the cataract surgery, because might be that is not going to help the patient?
Thank you very much for your question. I think there's no hard and fast rule of determining definitely a patient's visual potential, but we can make some educated guess. So in patients, if they have already scarred in their macula, or they have already multiple injections, the CMO doesn't regress with multiple IVTs, perhaps these kinds of patients may not have a very nice visual potential. But then, because having an early cataract surgery allows us to better monitor for other related complications to prevent a further visual deterioration. So perhaps we have to discuss with the patient of a very realistic outcome, and also to offer the surgery in these kinds of patients. I think that's most important.
Yeah, I usually use the Brigand test, very useful, you know. And I think is in these particular patients, it's important to know the visual potential to indicate or not a special lens, you know, because the visual potential is good. For me, it's a good indication for premium lenses, you know. The second is about people. You rightly pointed out that is one of the main problems, because you may have an adequate mydriasis, but intraoperatively it's difficult to control, you know. And then you have either to use in the pipeline adrenaline, which is not a happy issue in many patients because a systemic condition, and intraocular devices, such as Malyukin ring and others. So would you advise to have in every patient in which pupil dilation is not that brilliant, or patients that have a long-standing problem with a medical control, in which we know that people is not properly handled during surgery, an intraocular device, and this is the case, which one of the pupil retractor devices do you recommend to use?
May I, because I don't get it, can you repeat once more, sorry?
Yeah. No, the question is, which of one of the devices available do you think that is more useful for the practical surgeon to have it ready in case that the pupil doesn't behave well during the surgery?
I think it really depends on the patients to patients. In terms of, for example, viscoelastics, it depends on the patient. For example, in the patients with poor pupil dilation, perhaps we will use Helon GV, more strong, more rigid viscoelastics to try to enlarge the pupil. But I think it really depends on the patient.
Okay, thank you. Any other question?
George, no, regarding your first comment and question, I think I always counsel, I'm a retina surgeon, but work with the cataract surgeon closely. So I agree with whatever she presented, but this is a question patient asks because their friends or colleagues have the same age group, normal retina with the excellent visual acuity, and you have to lower their expectations. So I tell them it's like milk and water together. So how much is milk and how much is water, we can't predict. You may have a lactometer, but not in the eye. So I tell them whatever vision is blocked due to cataract may improve, and whatever due to retina, whatever the pathology may not improve. So I said you have to estimate that you will not get a normal vision, and then you do other potential acuity meter, and still, I think, lower the patient's expectation and do the cataract surgery.
Yeah, I echo and completely agree. Sometimes I use the analogy of a camera. I said that we are doing something to help with the lens, but we never know what happens to the film. Yeah, I totally agree.
Yes.
Thank you.
Thank you.
Thank you. Now the last speaker, It's an honor for us to introduce again to Dr. Kinoshita. He's going to talk about conflictive comorbidity, which is cataract and corneal disorders. Dr. Kinoshita is an expert on the topic, and I want to thank him for coming to this symposium. Thank you.
Well, thank you very much, Jose. Well, I think my role is something like cataract and corneal disorders. And then, this is my financial disclosures. Some companies' name highlighted in block letters are relevant to this presentation. Well, when we are thinking of some of the corneal disorders, and then we have to do the cataract surgery, that is, may have three different situations of the categories. One is corneal opacities or some of the ocular surface diseases. Second may be some kind of keratoectasia or some of the corneal deformation, including the keratocones, but they do not want to have a corneal transplantation. And third category is a corneal endothelial dysfunction, such as Fuchs dystrophy or the other type of the low endothelial cell density. So I think I am using the kind of 5 examples, and I'm a corneal specialist, but a standard cataract surgeon, like 300 cases per year, something like that, not a cataract specialist. But so therefore, to me, the most important thing is to perform the very safe and trustworthy surgery to the patient who asked me for the surgery. So using the 5 cases, and I'd like to show you my personal experience and also some of my know-how. This is a case one, 80-year-old male, corneal opacity and villus keratopathy after the posterior radial keratotomy, we called in Japan Sato's operation. And then he lost the left eye already by the glaucoma, but right eye has some of the reasonable visual field. So, but the several institutes in Japan, they denied to perform the surgery because it's so dangerous. So I performed just a regular triple procedure, but I'd like to perform the cataract surgery as well at the same time. So I think you may have a better technique, but to me, I'm almost always perform the spiral CCC. Try not to make the tears because of that. Using the small radius, and that could reduce the central fugal force. So I think there are a high percentage of the success of the CCC. Once CCC was performed, it's easy because this is an open eye. So, and then divide it to 3 or 4 pieces, and we can easily remove these 3 the pieces of the lenses. And then also CCC, if that is completed, it's so easy to insert the intraocular lens as well. And also for the eye aspiration, as long as the pore is upwards and there's no chance to tear or break the posterior surface. So this is just my usual technique for triple procedure. Maybe somebody argue about two-step procedure is better for this kind of patient, but for the senior patient, I think I'd like to perform the surgery at one time. So this donor cornea was imported from the US, iBank, but the cornea seems to be okay, but there's some of the exterior defects. But eventually, 4 years post-operative, visual acuity is reasonable in a single eye, and endothelial cell density is also the reasonable. So, for instance, spiral CCC, please try to do the spiral CCC. You have a good chance to make the CCC. And this is my personal experience about among the 164 eyes and 148 are successful, about 90% success. For that, I switched from local anesthesia to a general anesthesia using a laryngeal mask, because for the patient, this is so safe to perform for the triple procedure. So case 2 is, for instance, this is a keratoconus, so rather mild, and the other one is severe. So the rather mild case of the keratoconus, but she doesn't want to have some kind of a corneal surgery. So at that time, I tend to use a femtosecond laser-assisted cataract surgery. Well, femtosecond laser is a 1,053 nanometer for the eye surgery. So therefore, even though cornea has some of the opacity, they are getting into the through the corneal opacity as well as some of the corneal deformation. Either the LensX or the catalysis, which we can is available in Japan. Both of the I think the femtosecond laser is working very fine. So you can see, even for the keratoconus, it's a rather mild case, but the CCC is completed. But just to make sure, to every area is cut. And then once finished, and then there's already a radial cut is there made. So therefore, it's so rather easy to perform the cataract surgery as usual. So this is another case of the keratoconus, and this is more severe. So therefore, you could see some of the corneal folding, but still the attachment could be very well fit. So once fit, you could see the most of the part of the anterior capsulotomy was performed, but not 100%. So at the time of the femtosecond laser usage, we could define where we could cut, but some of the area is not cut. At this point, I think 1 o'clock to 3 o'clock position is not adequately cut. So therefore, using the forceps and then to peel that area. So in this case, CCC is completed. And also, there's the corneal opacity at the top, at the center of the cornea because of the keratoconus. But I think the already lens is divided into like 4 or 6 pieces. So the surgery itself is I would say, easy to perform. This is the 75-year female corneal endothelial dysfunction with cataract. Our endothelial cell is almost dead, but still, I think some of the portion is okay. But do you want to perform the just cataract surgery? No, probably you perform either the cataract surgery with the DMEC or the DSEC manually. But to me, almost always, as long as the pupil is dilated, we try to use the femtosecond laser initially to make the CCC and also some of the radial cutting or using the femtosecond laser. And the femtosecond laser, as I said, very easy to penetrate through the cornea, even though there are some of the epithelial edema as well. So this is, to me, it's a more safe procedure to perform this kind of surgery. So once finish the cataract surgery and insert the IOL in the bag, and then either they perform the DSEC or the DMEC procedure. In my case, I performed the DSEC procedure for this patient. But so in a very near future, we could convert from the DSEC or the DMEC to the cell cultured cell transplantation, the surgery, at least in Japan. So this is the DSEC procedure. So 1 month postoperative, she got the 20/20 vision without not much of the postoperative complication, and the endothelial cell density is about 2,000 cells per square millimeter, something like this. So this is the 75-year female, same thing, corneal endothelial failure, but it's rather severe, and also because of that, she developed some of the infectious keratitis in the lower portion, so there are some of the scarring at the posterior part, inferior part of the cornea. So it's a kind of a bit bumpy and also bullous, and there's no endothelial cell there. But using the femtosecond laser, we could manage the this anterior chamber, the CCC, as well as the radial cutting as well. So as I said, infrared laser can easily penetrate. Sometimes we are so feared to use a femtosecond laser, but for the cornea, if that is scarring, that we may not be able to use it, but even though FTL, severe FTL edema, that we could perform using the femtosecond laser. Okay. So the same thing, the cataract, easy to perform the cataract because of the pre-treatment by the femtosecond laser. And then we could easily put the IOL in the back, and then once again perform the DSEC procedure as well. So this is the about 3 months post-operative. Vision is about 20/30, something like that. So what about some of the problem at the time of the cataract surgery? We are very much interested in the use of the low kinase inhibitor for the treatment for some of the acute injury of the corneal endothelial the problem. So low kinase inhibitor, there are several low kinase inhibitor as a chemical compound. One is a Y27632, and also Granatec, I think made by the Kowa, Japan, or Netastio ophthalmic solution is used to made by the Eli Pharmaceutical, it's now Alcon. So either the low kinase inhibitor that could be applicable. So this is we use this is just one example, but we use the Y27632 and 1 millimolar of the eye drops 5 times a day, something like that for almost 3 months or so. After the cataract surgery, at the time of the cataract surgery, the surgeon, not intentionally, but accidentally removed the 2/3 of the descemet membrane, but the 1/3 of the inferior part of the cornea is still healthy. So therefore, using these eye drops, that could help promote endothelial migration, proliferation, and also anti-apoptotic. Eventually, cornea back to the normal situation. So the lock inhibitor eye drop is quite useful in patients with Fuchs endothelial corneal dystrophy as well. But if they have some of the defect at the time of the surgery, something like that, so I think that may be worthwhile to use it. But we are still not so sure about the good day or the low density of the corneal endothelial cells. So I think so. Therefore, the Kowa is now trying to perform the clinical trial called the K321. This is a low kinase inhibitor. And they've already finished the phase 2 clinical trial in the USA. That was successful and in combination with a DSO. And now they are performing the phase 3 clinical trial in combination in the US and EU. This is an ongoing project. So hopefully we will be able to get these eye drops available in a near future. Thank you very much for your kind attention.
Thank you very much, Haru. Now the time is open for questions. You have divided in 3 sections your talk. It's very nice. And the first was about ocular corneal opacity. That's good. And the most frequent problem we face in cataract surgery problems is in the ocular surface. Ocular surface is affected in the elderly patient. Many times we have patients with dry eye that comes for cataract surgery every day. And which is your policy towards optimization of the ocular surface pre-op?
So you're talking about some of the ocular surface and the dry eye related or whatever. So how can we do that before the surgery? That is the question?
Correct.
Yeah. So to me, for instance, a Sjögren's syndrome or whatever. So at that time, we first, of course, treated in Japan. We use levamipide and also glycosol sodium and try to improve the ocular surface to some extent, but not 100%. So, and then we just performed the cataract surgery. At the time of the cataract surgery, we tried to use the hyaluronic acid on the ocular surface and try to smoothen, to visualize more clearly inside the eye. So that's the way. And also, immediately after the surgery, especially the 1 month post-operative, up to a 1 month post-operative, dry eye becoming worse. So therefore, at that time, intensively, we use the treatment for the dry eye as well.
Important question. And second is about the use of drops, because we use about 15 drops at the moment of the surgery, because of the antiseptic, because of the anesthetic, because of mydriasis. This spoils a lot the ocular surface. So the trend is to decrease or even to not to use drops in these cases. Do you agree with this, or do you plan in any way to preserve the ocular surface in these patients in which you have already altered ocular surface?
I see. Try to decrease the drops. Yeah, I think depending upon whether they have I've said the preservatives, what kind of preservatives they have. So for me, really, I'm not so seriously thinking about that. So I think in the near future, I'd like to do.
We try not to use. We are dropless.
I see.
Now.
Okay,
Yeah.
thank you.
Second, about keratoconus. Keratoconus surgery is not difficult technically, but the problem is the lens. So do you use toric lenses always, or do you? How do you calculate the lens itself? You know that most of the patients have a trend to hyperopia, and which is the policy towards IOL calculation and choice that you do?
Well, I think I think, for instance, the DSEC or the DMEC procedure and the triple procedure, we aiming at about -1 diopters, and at that time it's rather easy. It's almost the same as just a regular cataract surgery. So using the Barrett formulation and the SRKT formulation, and then I think we calculated based upon the several data, and then we took the best choice in our experience. And for the triple procedure with the penetrating cataract procedure, that is difficult. But I think K-power is, I think I pre-set up in 43 diopters, and then I aimed at -3 diopters. So because at the time, immediately after the 1 month post-operative, the suture is still tight. So the corneal curvature to my hand, it's about 40 diopters, but then tend to go up a little bit, and then eventually that could go to the 43 diopters, something like that, in my hands. So therefore, -3 diopters, and that is okay. I think they have these patients, we are not aiming at the 20/20 vision for that patient. I'm aiming at at 20/50, something like that. So.
Thank you. Last question. We are all aware of your very successful and remarkable studies about endothelial cell transplantation, and Repasurdil. Obviously, the problem in these patients with Fuchs dystrophy is how to handle the endothelium, because we have a threshold of cells, but we have a behavior of the cells. And do you think that pre-op use of Repasurdil topically, several weeks before the surgery, can prevent further endothelial cell loss and to preserve the endothelium in a better way for cataract surgery in these borderline cases?
Well, I think in Japan, Japanese Fuchs endothelial dystrophy is rather mild as compared to the Caucasian the Fuchs endothelial corneal dystrophy. So therefore, I could not tell my answer may be wrong, but theoretically, rho kinase inhibitor is effective in an in vitro situation to improve the mitochondrial function even in a diseased Fuchs endothelial corneal dystrophy endothelial cells. So I think pre-treatment may be effective, but in vivo situation, we cannot prove that is effective at this point.
Okay, thank you very much. And any question, Dr. Natarajan? Nothing? Okay. Yes, please, doctor.
AMD. So once you have a geographical atrophy, should we undercorrect the power of the IOL?
I couldn't understand because there's equal here. Thank you.
I mean to say there is limitation of using telescopic lenses in geographical atrophy. Can we undercorrect the biometry of the eye in order to provide the magnification factor?
Thank you. Well, I think that I will answer the question. I have implanted about 50 of these devices in AMD, 50, and I cancel. I can tell you that the problem is the loss of peripheral visual field, and these patients have an evolutive disease. And the problem is that with an evolutive disease, you can have a temporal success or an initial failure, but finally, all of them fail. So this is, my opinion, the use of telescopic or magnified intraocular devices can be justified as far as you don't amputate the peripheral visual field. But the real telescopic lenses, based on Galileo principles, really limit the peripheral visual field to 20 to 30 degrees, and this makes the patient to be with no vision because central and peripheral visual field is lost. So how to calculate the lens? The company does it. You don't have any particular biometrical way to do it, and the company has to be given the instructions and the biometry and the key value, and they calculate the lens based on proprietary software. This answers your question? Yeah, thank you.
So do you have the experience with the IMD, the intraocular miniature device or the telescope?
Yes, I do.
For the AMD?
Yes, I have one paper published now 15 years ago, so this is not a recent topic. And the phase 2 of this lens, foldable, definitely it's a great advantage to have a foldable telescopic lens. But now the main indication for me is young patients with Stargardt disease. You know, all cases with AMD, I find it difficult because neuroadaptation problem, because orientation problems, and because evolutive character of the disease to be successful. So I have to tell you that I'm not using these devices any longer. They might be useful, but in young people. Yeah,
Good morning, everyone. I'm Dr. Aniza Nagpal. Wonderful presentation, sir. Great insights. I just wanted to know that you told that using a femto laser is advisable in patients with low endothelial cell count because it will also decrease the further loss during the cataract surgery as energy is lost once the nucleotomy is done and the rhexis is appropriate intraocular placement is wonderful. But like in ripple procedures you are doing like in DSEC along with, how will femto laser be an advantage? Anyway, we are changing the graft, like endothelial descending membrane is being replaced by the new graft. So how will femtosecond laser be an advantage in that case? Like a simple cataract surgery with a DSEC would be equally good, or will it make a difference?
Well, I think to me, for the safe cataract surgery, in Japan, most of the time we are dealing with the total epithelial edema with the corneal stroma edema. There's no scarring, but the visualization is not so impressive, even though you remove the epithelial edema. So at that time, I really want to do the safe 100% safe cataract surgery. At that time, CCC, complete CCC is critical, and not only for that, these patients had a rather hard nucleus, so at least in my experience. So I think we need a pre-chop if that is already performed, and that cataract surgery is so easy to perform. So that's we think.
And for cases where there is a paracentral corneal opacity and the patient is not willing to get DSEC or a triple procedure and just wants a cataract surgery and femtosecond laser will not be able to do, how do you optimize like your cataract surgery and be safe in that case?
You mean scarring? Yeah, scarring. For instance, as I already showed you, in a keratoconus at the center, for instance, at the center, we can easily perform the CCC as well as some of the partial, I think, radial the incision that could make. So I think the problem is whether we could make the very good docking or the pressure without any air. So even for the keratoconus, they make the folding that you could get the reasonably good the docking. So therefore safe enough for me.
Thank you.
Doctor, probably I can recommend to you as well, if you deal with an opaque cornea, to try to do the cataract surgery by endoscopic, endoscopic illumination. This is really remarkable. It makes you to make a different type of surgery. It's very beautiful, and many cases of conflictive outcome because you have limbal decompensation, you have vessels, you have bad ocular surface, really improve significantly, not a lot, but significantly with cataract surgery, and you avoid the hell of a corneal graft in these patients that most of the cases where you have chronic surface inflammation, etc., fails. And then you have a help for these patients. This is endoscopic illumination.
Okay, so that is how, by the pars plana chandelier illumination, or what are you suggesting, sir? How do we eliminate?
No, you use the endoilluminator from the vitreoretinal device. And
the chandelier system,
correct, 1 millimeter, and then you have a third entrance, and then you need to adjust during the surgery, because depending on the stage, you have to use or not, But the problem when this opaque cornea is the light scattering that you have, and the glare that you have, and this is totally eliminated with endoscopic illumination, and makes many patients with this third corneal graft failure, ocular surface inflammation, in limbal cell decompensation, a useful practice for them, and you can help a lot the vision of these patients, yes.
Thank you so much. That would be very helpful. Thank you.
Any other question? Yes, doctor?
Hi, good morning. I just wanted to know what is the role of toric IOLs in cases of paracentral corneal opacities and in cases of keratoconus. So whether we should plan a toric IOL in cases of keratoconus or keratoconus patients, or how to calculate the toric IOL power in these patients?
Well, I try not to use a toric IOL in this patient because they do not want to have the corneal transplantation, whatever. So I just use the monofocal, not toric, just a regular IOL. Usually, these patients, I selected almost the 6 diopters or something like the lowest, IOL calculation based upon the calculation. Because they like to wear the hard contact lens afterwards.
Yeah, in general, you should not use toric lenses when corneal graft.
Okay, sir.
You should not.
Thank you.
That's it, Yeah. Okay, the last question, the last one.
Good morning, everyone. Sir, what is your take on, suppose a controlled diabetic patient with no macular edema, can we go for multifocals? Suppose he or she is 45 years of age now, and we know that later on, at some time of life, she will develop maculopathy later on. So what is your take on this, sir, about multifocals and EDOF lenses?
Let me tell you what I do. I study with the macular function test. You can have the potential acuimeter, retinal acuimeter, or the Briggen test. Either of them are good. And if you have a good visual potential, means that the patient will be almost 20/20, almost, not 20/20, but almost. I definitely use, if the patient is young and active, multifocal lenses or EDOF. EDOF are probably more tolerant, and if you want to be in a little bit more conservative, EDOF are good. EDOF, you have several, and you want to see how to classify and to choose. You have one of my papers in journal, as a specific journal of ophthalmology dealing with EDOF lenses, and you can read this, is my opinion. But I do use multifocal lenses as well if the patient needs. The issue is that macular function is not that much affected many times in these patients because macular control and macular edema is well treated today. At least in Europe, in Spain, we have the patients that with good visual potential, and they can benefit a lot with the advantages of premium lenses. But if you have any limitation or doubt, better to use only EDOF or monofocal. This is my personal attitude.
Thank you so much, sir. Sir, one thing I want to add. In this era, I think pre-opacity is very essential because I have in my practice missed 2-3 cases of foveal thinning, which can never be diagnosed on fundus examination, what ma'am was saying. And in this era, because of the litigations over the doctors, so I think pre-opacity is mandatory in every cataract patient.
Macular thinning is not an indication for any premium lens, doctor.
Sir, post-operatively, I diagnosed a decreased vision. Patient complained out to me that I am not getting good vision. And then I sent him to some other doctor for OCT, and there she was diagnosed foveal thinning. Now I have purchased OCT, sir, for this reason.
Yeah. We can discuss this later, you and me, because I think it's more particular, okay? Okay, I think we should close the session, Dr. Andrayan. I have to tell you that this is not about the session, but today we released this book about the new type of corneal surgery, which is corneal pigmentation. This is very useful for patients with corneal lymphomas and blind eyes, but it's very much now on the rise because of therapeutic and functional indications. Just to tell you, this is JIP Brothers, and the book is released today in the booth of JIP. And I want to thank all the speakers, Dr. Aung, Dr. Sivarasa Prasad, Dr. McCluskey, Dr. Chan, Dr. Kinoshita, because of their very kind and very useful pearls for cataract surgery with comorbidities. Thank you very much, and the session is closed. Thank you.
Congratulations for the book, Dr. Jha.